Hello, everyone, and welcome to today's CalMap webinar on anxiety and depression, commonalities, differences, and convergences. I'm Joanne Jung, Senior Associate Director here at CalMap. We're very lucky to have with us two of our wonderful consultants and speakers. But before I get to introducing them, I'd like to go ahead and just share a little bit about relevant disclosures. And the short word is that there aren't any relevant financial conflicts of interest to disclose for any of the planners or the speakers today. You can see on this slide here a quick word on some of our funders from the state as well as the feds. And these are our learning objectives for today. But here I'd like to go ahead and introduce our speakers. Dr. Michelle Riederer is a child and adolescent psychiatrist and assistant clinical professor in the Division of Child and Adolescent Psychiatry at UCSF. She is also CalMap's Associate Director for Community Engagement and Liaison. Clinically, she serves as the Director of the UCSF Benioff Children's Hospital's Pediatric Psychiatry Consultation Liaison Service, and she specializes in providing psychiatric care to medically ill and hospitalized youth. Our other speaker is Dr. Lauren Schumacher, an associate clinical professor of psychiatry in the UCSF School of Medicine. She serves as a child and adolescent psychiatrist for the Division of Mental Health and Child Development, the UCSF Benioff Children's Hospital, Oakland, and in the Division of Child and Adolescent Psychiatry in the UCSF Department of Psychiatry and Behavioral Sciences. She's also served as a long-time member of our planning committee for CalMap CME and consultant, and has done a lot to help organize our educational events. So I'll go ahead and hand the virtual mic over to my colleagues, Drs. Riederer and Schumacher.
Thank you so much, Dr. Jung. Just had to take a moment to figure out how to unmute myself, as always happens. So happy to be here with you today. And this is the first year that we're actually combining our depression and anxiety talks and really talking through, kind of a longitudinal case where we'll go into sort of the differences and similarities and walk through anxiety as well as depression, which we see so commonly in our, pediatric population. So I just wanted to go back to try to see if I can go backwards for a moment. The learning objectives and briefly review those. We're going to discuss screening and diagnosis of depression and anxiety in primary care. We're going to discuss developing a treatment plan for pediatric depression and anxiety disorders, including when to consider medications, referral to psychotherapy, and consultation. And then we will compare the similarities and differences, as I mentioned, in the presentation and treatment of pediatric anxiety and depression. So briefly before we launch into our case and more of a discussion about anxiety, I just wanted to mention that as many of you are probably aware, depression and anxiety are extremely common in youth, and the prevalence is rising. And I think we all see this anecdotally in our clinical practice. The prevalence is about 13% in young people for depression and very similar 11.6% in anxiety. The kind of trajectory over development is slightly different. We tend to see anxiety disorders emerge earlier in youth, in age, and then peak around early to mid adolescence. Whereas for depression, we see it sort of peak around the adolescent time, and that incidence is sustained through sort of early adulthood and into, somebody's 20s and 30s. When we see anxiety disorders in a young person, usually especially under the age of 10, that tends to look really different and present very separately from depression. But as children get older, these two distinct disorders often tend to converge. And so by adolescence, it is very common to see a teen with anxiety and depression. And in fact, we have some data in terms of, kind of the comorbidity of depression and anxiety, and the rates are very high. Almost 50% of depressed youth will have anxiety, and about 10 to 15% of anxious youth have depression. Often the story that we'll hear is that anxiety comes first. As I mentioned, it tends to present kind of in the earlier and peak in the earlier ages of school-age children and early adolescence. And then after anxiety, it's not that uncommon to develop depression afterward. So what is the takeaway here before we even jump into the case and the discussion? It's really important to screen for both. If you are concerned about anxiety, it's important to follow up and make sure that you're catching depression if it's there. And if you're concerned about a mood disorder like depression, it's important to ask about anxiety and worries and make sure that you're addressing anxiety as well. There are some other commonalities, including, what we think about psychologically in terms of sort of a negative bias in information processing. So tending to sort of process the outside world with a particular cognitive style that tends to, reframe things in sort of a negative or sort of hopeless type of style. And then there's also a lot of commonalities in treatment that we'll discuss in our talk today. Trying to advance. So now I will pass it over to Dr. Schumacher.
So we have a case that we're going to kind of carry through this discussion of anxiety and depression. So when we first meet Sienna, she's a sixth grader who's presenting to her pediatrician with persistent worry about school performance. She's been having stomach aches before school and difficulty falling asleep. This has been kind of going on for the last 6 months, but over the last month or so, she started missing a few soccer practices and has become late to school by 30 minutes to an hour due to morning meltdowns. So when we're thinking about anxiety, and with Sienna, she's kind of coming in with some worries. Parents are worried about anxiety. What are we thinking about? So there's kind of both a cognitive piece and a physical piece to anxiety. You can have this, like the feelings part of overwhelming sense of apprehension and fear, have the fight or flight response triggered, increased heart rate, breathing faster. There's also a cognitive piece of worried thoughts, doubting one's ability to cope. And I think a challenge with anxiety, an important thing to keep in mind is everyone experiences anxiety. So this is something we all experience. And it can be helpful that it's there because it can help prepare us for threats, keep us safe. And the goal is really not to get rid of all anxiety, but to reduce distress and help people function better. So when we're thinking about anxiety, there's kind of this nice graph here that kind of goes over level of arousal. So if people, it's like too low, then you're, kind of asleep or not getting done what you need to get done. And there's a certain amount of kind of anxiety that helps us, show up to things on time, get that, study for that test that we have coming up. But then if there's too much anxiety, it then starts to get in the way of our functioning where, you're so anxious for the test that you avoid studying for the test, or that you don't even go to school that day, and then it can cause a lot of distress. So it's helpful to think about some things that distinguish kind of clinical anxiety disorders from normal anxiety. Is thinking about, is it developmentally appropriate? Is it interfering with functioning at home, with friends, at school? And are they able to recover from it? So is this something where they have something stressful happen and they're stressed out but then feel better? Or is it something where this happens and they're kind of get stuck there? They continue to worry about it. They worry about it happening again. It's they can't move forward. And a helpful mnemonic for this is to think about the 4Ds. So thinking about dysfunction, distress, duration, and deviation from developmental trajectory can all be kind of signs that this is tipping over from kind of normal anxiety to an anxiety disorder. And I like this graph as kind of a nice overview of thinking about anxiety across development. So they're kind of at the bottom, we have normative fears. So there's different kind of fears and challenges that kids face at different developmental stages. And the anxiety disorders actually kind of follow a similar pattern. So with kind of younger kids, they're dealing with kind of fears about separation from caregivers, stranger danger, things like that. And that can be normal. But then if it's getting to the point where it's causing lots of distress, it's deviating from the developmental trajectory, so it's kind of sticking around longer than is developmentally appropriate. It's kind of getting in the way of their functioning, their ability to kind of go to school or daycare, then that then tips it over into an anxiety disorder. And then similarly, kind of moving into childhood, early school age, we start to see worries about kind of natural disasters, the dark, monsters, and then kind of a similar uptake on the disorder side of if they're so bad that they're causing impairment, distress, that then we have specific phobias popping up, as well as generalized anxiety disorders starting to sometimes show up. And then as we get into more later school age, where worries more about school performance, negative evaluation, start to see some social anxiety. And then especially as we get into the adolescent years and lots of worries about rejections from peers and judgment, that we'll see even more anxiety disorder. And these are things that kind of the blue arrows take us through. There can be different courses. It can be something that waxes and wanes over time. It can improve, it can persist or progress over time. And we worry about anxiety disorders because when there aren't interventions that are not treated, that they can kind of accumulate impairment over time. And we'll see things, that might start as just anxiety, but ultimately also develop depression, might impair school performance, lead to isolation, less social connections and development. So the USPTF recommends screening for anxiety in ages over 8, and there's a number of helpful tools for that. The SCARED is one we commonly use. It's for ages 8 to 18. A nice thing about the SCARED is it has a parent and self-report, which can be helpful to get that parent perspective. And it looks at a number of different anxiety disorders. The downside is it's pretty long. It's 41 questions, so that can be a big ask both for families to do and for clinicians to score. There are some Excel sheets online that can help with scoring it. Probably the most common one people use is the GAD-7. The nice thing about that is it's short. It's focused just on generalized anxiety, but can be helpful in teens for both diagnosing it and tracking response over time, since it doesn't take too long to fill out. And then there's the Spence Children's Anxiety Scale, and the Spence Preschool Anxiety Scale is nice because it has a parent version for 3 to 6-year-olds. So if you're worried about anxiety in that younger group, that can be a good choice. And then the RCADS looks at both anxiety and mood disorders and OCD. So can be a helpful option when you're worried about both anxiety and depression. And so in Sienna's case, we have an example here where her parents filled out the SCARE. They kind of, on each question, say whether it's not true, somewhat true, or very true. And then we add those up, and that gets you a total score as well as subscores for a number of different anxiety disorders. So in her case, the parent one was positive for the total score, so kind of high likelihood of an anxiety disorder being present, and then in particular scored high for somatic symptoms, generalized anxiety, and separation anxiety. So then maybe you've done one of these you're hearing some things concerning for anxiety, you've done one of the screeners, it was positive. Where do you go from here in terms of diagnosis? So when you're diagnosing anxiety disorders, the screeners and scales can be really helpful as a piece, but that alone isn't sufficient. You want to combine that with kind of your clinical interview with the patient, clinical interview with the parent, physical exam, and kind of combine that all together. There's a lot of different anxiety disorders, and I think it can be kind of confusing sometimes, like, is this general, is this social? I would say that if you're a therapist doing kind of CBT to treat anxiety, it's important to know which exact that anxiety disorder is. In the primary care setting, I think what's more important is saying, like, is this normal anxiety? Is this an anxiety disorder that needs treatment? And that kind of big picture gestalt is what matters most. So I would focus on that. And like here we have highlighted, this is the DSM criteria for your guys' reference, but these orange boxes are highlighting some of the commonalities. So for all of them, there's the duration piece. Most of them, it's over 6 months. So you're looking for, has this been around a while? the impairment. Is this causing impairment and significant distress? And then thinking through the differential diagnosis, because you guys as pediatricians are in the position to best think through, is there something else going on? Is there concerns for hypothyroidism? Is there excessive caffeine intake? Something else that might be looking like anxiety. So with Sienna, we saw the parent scared, it was positive. The child one that Sienna filled out also was positive with a score of 40. And based on that, as well as additional interview that the pediatrician did, she was diagnosed with generalized anxiety and separation anxiety disorder. Her PCP provided handouts and some books about anxiety for the parent and Sienna to look at together, and also recommended that the parents ask for an IEP from school since the anxiety was getting in the way of her getting to school. And additionally, recommended therapy, and that's something that the parents are currently working on trying to find a therapist. So I'm now going to pass it over to Dr. Riederer for the next part.
You. So now we're looking at Sienna's vignette from 3 months later. Dr. Schumacher mentioned that she, has gotten this diagnosis of anxiety. She started with some interventions, including therapy and some changes at school with her IEP. And now she's coming back to your office and she's reporting, and her parents are reporting that Sienna has been more irritable recently, and she's fighting more with her brother and her parents. And she's refusing dinner sometimes. She's preferring to spend more time alone. She's also reporting more headaches. And previously, she had reported some stomach aches, and that's continuing. And she once told her mother that she feels she's not worth it, and she believes she's a bad person. And so, because we're thinking about the commonalities between anxiety and depression and how often they co-occur, the next part of our exploration of what's going on with Sienna and how we can help her, we'll want to do screening for depression. The USPTF also recommends universal screening for depression for any adolescent aged 12 to 18 using the PHQ-9. And I know that many of you are already doing this in your office. And so this is a pretty quick screener for a teen to fill out. It maps on, the questions map on directly to some of the criteria that we need for diagnosis of depression. And the cutoffs are, relatively easy to remember. Just thinking about 5, 10, 15, and 20 as the cutoffs, where 5 is sort of sub-threshold potential concern for, something brewing or a mild case. 10 is the official positive screen for depression. And then 15 is more moderately to severe, and 20 is more severe. And so the number, while, as Dr. Schumacher mentioned, the screener does not equal a diagnosis, and the number does not mean, absolutely that when you have 20, that you have a severe depression, but it can be nice in terms of just starting to give you a sense of what's going on with a child, and of course, accompanied with more questions and your interview. And for younger children, where the PHQ-9 is not validated, the short mood and feelings questionnaire can be helpful as well to elicit depression symptoms. And both of these screeners are available on the CalMap website. I'm sorry, I'm for some reason, having so much trouble with the remote. I'm trying to go backwards. Dr. Jung, if you could help me go backwards. I think we're still going forwards.
Go ahead and try again. I think you should have control.
Okay, thank you. Okay, so anyway, I had shared that, the screener is a wonderful tool to start off with, but we really want to have a conversation with the teen, the patient, and ideally from another source, such as a caregiver or a parent. to really understand what's going on. With teenagers, it's important to discuss confidentiality and ideally, if possible, to invite the patient to speak with you separately from the parent because there may be parts of their experience that they're not feeling comfortable sharing with their caregiver, a parent in the room. And then it's always important to ask. I think if you do have the PHQ-9, it's a really great jumping off point to point out that, oh, I noticed that there's a couple of things that you have shared here that you're struggling with. It looks like you've written down that you're struggling with sleep, that you're feeling low, down, depressed, that you're feeling like your energy level has changed. Whatever it is that they're kind of sharing with you could be a nice place to start from, to just ask about what's going on with them, what has been stressful recently, what's changed, and start to invite a conversation about their mood. Next slide, please. Thank you. And then for the diagnosis, here is a list of the DSM-5 criteria. I want to highlight some of the similarities in terms of what Dr. Schumacher shared with anxiety. What we really want to think about for diagnosis is sort of the duration of the symptoms. So for the DSM-5 criteria, the symptoms have to be present for the last 2 weeks. It can't be sort of that they, had a sort of a roller coaster of emotions and yesterday was a particularly bad day. And then also we're thinking about, as Dr. Schumacher mentioned, the level of impairment of the symptoms. So as we know, changes in mood and fluctuations in mood are, quite normative and part of the adolescent experience. And so the impairment, as well as sustained duration of more than 2 weeks, and whether it's impacting sort of their ability to function, really would then move the diagnosis from, sort of normal sadness to a more concern about depression. And then with the DSM-5 criteria, we're also looking at sort of like the, the number of different symptoms that they're having that could be related to depression. And so technically to meet criteria, there would need to be 5 or more of the following symptoms, either depressed mood or irritability or anhedonia, which is, loss of interest or pleasure in usual activities that used to bring interest and pleasure. And then changes to sleep, feelings of guilt, low energy, changes to concentration that might manifest as just difficulty making decisions, changes in appetite, psychomotor, that's like slowing or even more restless, and then potentially suicidal ideation. Of course, that's a red flag for you to explore more about how their mood is and whether they're experiencing any depression. Next slide, please. And so I started to mention, for depression versus normal sadness, the duration is really important, the severity of the symptoms, with more of the DSM criteria, meaning that something is more severe, and then how does it interfere with the functioning? And usually for a teen or a young person, functioning is across 3 domains. Socially, so how are they getting along with their peers? Did they used to have friends and now they're isolating from friends, or kind of, sort of losing those peer groups or friend groups? How they're doing in school, that's essentially their equivalent of work, and how they're doing at home with their family. Next slide, please. And I just wanted to bring it back to Dr. Schumacher's 4 Ds of, really differentiating when it's depression versus when this is something that might be a little bit concerning and you might want to watch and wait, but might not warrant for fully jumping into sort of the diagnosis and discussion of treatment and referrals and so on. Next slide, please. And I also wanted to highlight, that for youth, similarly for anxiety and depression, Dr. Schumacher had this wonderful slide of like basically all the normative parts of anxiety that occur over childhood. And, we also know that mood can change across someone's development and across age. And so when there is a disruption to that, and which manifests as depression, that can look really different depending on the age of the child and their ability to express sort of their internal, processes and feelings. So for a preschool child, somebody who's more sort of withdrawn, not playing as joyfully might be the sign that there is a mood consideration to further explore. For school-age children, they may not be, expressing feeling sad or feeling low or hopeless. They may manifest more with irritability, more frustration, more tantrums, somatic symptoms, even anxiety as well, or, experiences that might at first seem very concerning, like hallucinations, but are truly sort of manifesting as their expression of sort of that things don't quite feel right for them. And then for adolescents, they often present more with what we think about as sort of the depression picture of saying that they're feeling sad or they're feeling low, more neurovegetative symptoms, which are, sleeping more, changes in appetite, as well as, thoughts about not wanting to be alive. Across the spectrum, depression can present differently, and there can be such a range in terms of how depression looks for each individual. I mentioned the PHQ-9 can, help you to determine if it's something is more mild or subsyndromal to moderate to moderately severe. And we also just know that, somebody could experience more transient mood states where things go up and down to more sort of mild depression to really severe clinical depression where they're they're checking off everything in that PHQ-9 and, they're thinking about wanting to end their lives. And then I just wanted to make one note that there are modified criteria for patients with intellectual disability. And so not only should we consider the developmental age of the child in terms of, how they might present with depression, but also, kind of considering sort of the patient and whether they have any, cognitive or intellectual disability or limitations. And so there's a specific modified criteria called the DMID2 that you can use. It just basically looks at the DSM-5 and there's a column next to it that will let you know like whether or not there's any changes or potential modifications to that criteria. Next slide, please. And then as, Dr. Schumacher was saying for anxiety, we really want to think about the differential. And we also want to keep in mind that, depression could present with, like depression, have a lot of, different medical causes that are posing as depression, such as, different medications or autoimmune conditions or other conditions, but that also comorbidities are common. So it could be, sort of part of your differential diagnosis. And it could also mean that, there's something medical going on and the teen or the child is struggling to cope with that, or that's really impacting their functioning, causing downstream depression. So just sort of both are possible. And we also want to consider that there could be other psychiatric comorbidities, which are very common, 40 to 90%, including, of course, this talk, anxiety, but also ADHD, substance use, trauma. So there's a huge range really. And I think personally, clinically, I found that, the DSM is, nicely sort of clear cut. This is what depression looks like. And that may be more true for adults, but I think for kids, so much of the environment is so important. And so typically it's rare that I found a child or a teen with like a purely biologic depression where, we just think they were fine and then suddenly they have depression and nothing happened to them. And so I think it's really important to zoom out when you do have a child with depression and to consider what's going on at home, what's going on in the child's life, what are the other things going on, what's going on physically, because we don't want to miss some of the factors that might be perpetuating the mood disorder. Next slide, please. Okay, so now we'll talk a little bit about treatment in a combined format. Next slide. So with the PHQ-9, that's a good tool to help you kind of distinguish between, a mild condition, moderate condition, severe depression condition for depression. And usually when we're thinking about the treatment, we want to really start with sort of like psychoeducation for all of the patients, education about what's going on, sharing a little bit about, your diagnosis and, what might be recommended next. So that's the education part. That's included no matter if you're looking at a subsyndromal mild depression or a severe depression. And then sort of the, kind of determination of your treatment plan sort of depends on how severe the symptoms are. And this is kind of a triangle where you can see active monitoring and education is part of the mild recommendation. So let's go to the next slide to see a little bit more in detail what the treatment plan can look like. This is a algorithm that we have on our CalMap website for the treatment of depression. And it takes you through, if you start with a concern and you do the PHQ-9 or the short mood and feelings questionnaire, you always want to do a safety check and just, make sure that there's no safety concerns in terms of thoughts of harming self or others. And then this divides it up into mild, moderate, and severe. And so I mentioned the psychoeducation piece, and then sort of active monitoring is basically, following up, continuing to monitor for symptom worsening, tracking rating scales. So following up with, an additional PHQ-9 in your next visit and making sure that this, we're doing a safety assessment there. Also in mild depression, you may consider referral to psychotherapy anyway. And if it persists, depending on sort of if there's more impairment or functioning changes that are happening, then medications could be considered after psychotherapy is tried. Similarly, for moderate depression, all kids should receive some education and support and monitoring with rating scales tracked at follow-up visits. But you would want to recommend psychotherapy right away at that visit. And then if there's, limited improvement or if things worsen, then I would, quickly move to medication treatment as well. And for severe depression, when the score is over 15 or over 20, then you would consider, again, the active monitoring, psychotherapy, but potentially initiating medications right at that first visit if, the teen is, experiencing a moderately severe or severe depression. That's a PHQ-9 score over 15. And I will pass it to Dr. Schumacher.
So then on this next slide, we have the CalMap algorithm for treating anxiety. And I'm not going to go through it in detail, but just wanted to mostly highlight how similar it is to the approach for depression. So kind of very similar in terms of using rating scales as well as interview to kind of make that diagnosis, including a safety check. And then you can use, in the anxiety case, something like the GAD-7 to help separate out mild, moderate, or severe, and kind of a similar pattern of kind of psychoeducation focus for the mild, with moderate thinking more about that plus therapy, and then for severe thinking about education plus therapy and medication. And now we're going to dive into more detail on that. So in terms of psychoeducation, we have a number of resources for families on our website. For anxiety in particular, there's a lot of great books such as What to Do When You Worry Too Much, which is a workbook for kids that the kid and family can actually work on their own. And I especially like these for kind of maybe more mild anxiety where it's a problem, it's causing some challenges, but it's not so distressing or so impairing that we're thinking about maybe not even maybe diagnosing an anxiety disorder yet, but it can still be skills that the parent and family can work on that hopefully can prevent it getting worse in the future. Other great resources, there's Bright Life Kids and Soluna, which are Cal Health programs for kids and teens respectively that offer a lot of kind of online behavioral tools that are free to kids and families in California. And there's for depression some number of helpful apps like Mindshift and Calm that work on kind of different strategies and like mindfulness that they can kind of practice on apps. And then, so once you're at the kind of moderate or severe level, we want to think about referral to CBT. And when you're referring to CBT, you want to coach parents to be looking, some of the principles of CBT is that it's time limited, skills-based, and goal-oriented. So prompting kind of families to be going in with some goals they're wanting to work on. They should expect to have some, skills that they're practicing between sessions. And for youth, it's important to have the kind of family and parent involved as well. And kind of what we think about with CBT is there's this concept that kind of thoughts, feelings, and behaviors are all connected and interacting with each other. So like in the context of depression and anxiety, you're, feeling depressed, feeling anxious, you are expecting bad things to happen. There's that negative cognitive bias that Dr. Riederer mentioned earlier. And then that leads to maladaptive behaviors where like you're very anxious, you're expecting, you're worried about that test, you're expecting to do poorly, so then you avoid studying or avoid going to the test at all. And that causes more problems than if you just had done it. And with depression, often it might be like, more inactivity, that they're not getting out of bed, not, they're expecting that their friends are thinking poorly of them. So they stop reaching out to their friends and isolate. And with CBT, the idea is we can kind of intervene at all these different levels. But really often the meat of it is at the behavioral skills. So with depression, especially an emphasis on behavioral activation, the idea that when we're depressed, we're doing things that make depression worse, not getting out of bed, not taking care of ourselves, isolating, and that doing the opposite of that can actually really help with mood. And with anxiety, often it's the meat of it is exposures. So when we're anxious about something, there's the fight or flight. Flight, we avoid it. And doing the opposite, like gradually working up over time to exposing ourselves to what makes us anxious and tolerating that distress teaches our brains and our bodies that it's okay and we can manage it. And I like both of these because even in really short visits, there's little kind of nuggets that you can encourage kids and parents to be working on. And while we can think of behavioral activation more for depression and exposures for anxiety, opposite action is kind of a concept that encompasses them both. So opposite action is the idea that we are encouraging kids and parents to be trying to do the opposite of what the depression or anxiety is telling them to do. And we ideally want them to be working on this with a therapist, but it's also something they can be working on kind of on their own with family support while they're trying to get linked with therapy. And then in terms of the feelings, there's also emotion skills like learning to identify feelings, practicing distress tolerance, and in terms of thoughts, cognitive skills like practicing cognitive restructuring, noticing when they have kind of thinking biases like expecting the worst outcomes and trying to catch those. And those are all pieces that they would work on in CBT. So then with coming back to Sienna, she starts seeing the school therapist weekly for 30 minutes. And she and her parents feel like it's helped a little, but would also like to think about exploring antidepressant options further. There's no family history of depression or previous trials of antidepressants. So when to think about medication for anxiety, depression, or both? Some kind of guidelines to think about. Between different SSRIs, they have pretty similar efficacy at a population level, but we know that some individuals do better with some compared to others. Often past response, side effect profiles, and coexisting medical conditions kind of can help narrow it down. It does take time, so it can take 4 to 6 weeks between a therapeutic dose and kind of to see the full benefit. And if kind of there's no improvement after 8 weeks at an adequate dose, thinking about switching, optimizing the dose, or augmenting with another agent. And in studies, with both anxiety and depression, we see that SSRIs show significant improvements compared to placebo, but we actually see, especially in younger children, anxiety disorders kind of have more benefit. And part of that is in the depression trials, there's a pretty robust placebo response. So there's less difference between the response to SSRIs because both groups get better. And so when to think about prescribing in primary care. So one is if you've got you're on the more severe side, there's significant functional impairment. If they've kind of been trying therapy and they either haven't been improving or had only partial improvement with therapy, then you might want to think about adding on medication. You need to kind of have buy-in from the parent and patient, have them be aware, have some understanding of the risks and benefits, have a relationship with the patient, be able to monitor them over time. And it's helpful to be able to have kind of ability to consult and collaborate as well. And CalMAP is a great resource for that. If you're thinking about starting SSRIs, can give us a call to kind of discuss in more detail. So in children and adolescents, there's kind of three SSRIs that tend to be our go-tos. One is sertraline, fluoxetine, and escitalopram. And all of these have FDA approval in youth, some for OCD, some for MDD, some for GAD, but we use all three of them as first-line agents for anxiety disorders and MDD, and in patients where we see both. They're all reasonable first options. Sometimes if there's a personal history of a good response to one, we start with that. If there's a family history of a good response, that can be a good starting place as well. With sertraline, it can be slightly sedating, so that's often our go-to with when anxiety is the most prominent piece, and it's somebody who's pretty anxious, more restless, and like a little bit more calming effect would be helpful. With fluoxetine, it tends to be the most activating. So is often the one we think about if it's more depression is most prominent and somebody with more of those neurovegetative symptoms, low mood, low energy, and that activation might be helpful. It also has the longest half-life, so you're least likely to see discontinuation symptoms, and it's a good choice, especially like if it's a teen that maybe sometimes forgets their medication or isn't the most reliable in taking it consistently, it's a good option for those patients. And then escitalopram tends to be pretty well tolerated. It has fewer drug-drug interactions, so it's a good option to think about if it's a patient who's taking other medications. And these are some of the more common side effects. As a general principle, kind of starting at a low dose and working up the way up gradually can help with side effects. Often things like gastrointestinal distress, headache, appetite change might present initially, but then kind of gets better over the course of like a week as their body gets used to it. So I often encourage kind of if there's side effects, but they're kind of mild to moderate, to try to wait it out a little bit and let their body get used to it and see how they feel. Obviously, if it's severe, they should just stop the medication and reach out to us and we can think about something else. Sometimes it can be a little bit sedating. If so, it's helpful to take it in the evening. For some people, it can actually disrupt sleep some, so have them take it in the morning. If there's concerns about issues with sexual side effects, can think about a medication change or can think about augmenting with bupropion. And I'll turn it back over to Dr. Riederer here.
Thank you. So when you're thinking about prescribing an SSRI and when you're starting to talk to a family about an SSRI, it's always important to mention the black box warning because, when the family picks up the medications, they're going to see this. And it's important to, talk to them about it. And also very important to ask about suicidal ideation before you start the medicine so that you have a baseline to compare it to if there's any concerns about suicidal ideation coming up after you start the medication. So the black box warning says that there's an increased risk of suicidal thoughts and behaviors in youth up to the age of 25. This black box warning was instituted in 2004. It's based on about 24 studies with 9 different SSRIs and 4,000 youth. And there was a slight change, sort of a slight difference in terms of the suicidal ideation and self-injurious behavior that they saw in patients on SSRIs versus on placebo. But the difference is actually, very small. It was 3.8% versus 2.2%. There was actually no increased in suicides in these studies between patients who are on medications and on placebo. So that's why the warning says there's an increased risk of suicidal thoughts and behavior such as self-injurious behavior in this population. And we also saw that after this black box warning came out, when they looked at other studies, there are many that did not actually show this difference between medication and placebo. And so, takeaways from the black box warning, always discuss the black box warning with families if you're starting an SSRI, and know that the highest risk is in the first 9 days of treatment. It's higher if you, start at high doses. So as Dr. Schumacher was mentioning before, here's another good reason to kind of start low and, go slowly up, just in terms of, minimizing risk for side effects and minimizing this risk for suicidal thinking and behavior. Next slide, please. But I think the sort of takeaway is that you would want to, make sure that you kind of assess for the, pre-starting an SSRI, if there's any suicidal ideation or thinking or behaviors before that, because you would want to only sort of intervene and potentially change your plan if there's a change after the SSRI. And I think what happens for a lot of patients is that, they if they're depressed or they're anxious, they may already be manifesting some of these symptoms as part of their depression and anxiety. And so we would hate to sort of eliminate, a potentially really beneficial medication for them that could really help alleviate their symptoms just because we weren't sure, whether this is related to the medication or related to something that was pre-existing. And what I always say to families is, even though there's this slight increase, 3.8% versus 2.2%, what we do know is that these medications are extremely helpful for treating depression, for treating anxiety, and the risk is very low. And so the recommendation is still to make sure that we do treat it with a medication, and to, of course, monitor for any changes, any acute changes, especially in the beginning of treatment. And that the risk is higher with higher doses. And that's why we're starting with this kind of introductory low dose. And this just kind of highlights, sort of the number needed to treat. So the benefit versus the risk is the difference there is huge, right? So again, really trying to provide some reassurance to families, make sure that they know that you know about this risk and that it's still your recommendation that, the medication is indicated and could be helpful, and that you're going to be helping them through anything that does come up. Next slide, please. So a question that might come up with SSRI treatment, especially for as you're having this conversation, is how long will my child be on this medication, or how long will I have to take this medication? And it's hard to provide an exact amount of time, but generally I share that we would want to wait until symptoms improve, and sometimes that can take some time in terms of what Dr. Schumacher shared. It takes 4 to 6 weeks for an SSRI to usually kind of have its effect, and that's more at a therapeutic dose. So depending on the medication that you're prescribing, it may also take some time to ramp up to that therapeutic dose. And so after, they're on their therapeutic dose, symptoms have started to remit or improve, we generally recommend that, patients stay on it at least 6 to 12 months, and then they can start to taper off of it with your guidance. And of course, if, things happen after that, then, you can always know that that's a potential option for treatment in the future. But it does not necessarily mean that, you're starting this medication. It doesn't mean that they're going to be on it for the rest of their lives. It's sort of just a tool in terms of helping them to be able to, live the life that they want to live. And often, you're already recommending psychotherapy before or in conjunction with the medications, and to really emphasize how the two work really well together. And so, kind of that there's not only this one medication that's going to treat, what they're going through, but also sort of psychotherapy, support from, family, changes to the school, the IEP, all these other parts of their environment that can also lend support and help with recovery. And finally, so just to wrap up, we've been sharing throughout this presentation how anxiety and depression can look so similar, how often they're comorbid, how they present together in many patients, and sort of how there are some similarities in treatment. So, behavioral changes can be a sign of anxiety in youth. They can be also a sign of depression. So, for example, irritability, somatic symptoms like Sienna had changes to appetite or sleep pattern, social withdrawal. Those can be signs of either anxiety, depression, or both. Therapy is the primary approach for anxiety and depression when it's a mild case, and medication plus therapy is the recommended and best treatment for moderate and severe cases of anxiety and depression. And as we just mentioned, sort of comprehensive multimodal treatment is ideal, and that's really key. So especially in more complicated cases, like Sienna's, you'd want to address anxiety and mood with sort of a plan that includes both, or includes medications, potentially, includes therapy, ideally CBT, includes school accommodations and family psychoeducation and support. Oh, and Dr. Jung, if you're there, we go.
Yes. I'm going to come back to questions in just a moment because we do have a few from the audience, but I want to make sure that everyone knows that CalMAP offers this warm line where you can talk to psychiatrists like Dr. Riederer and Dr. Schumacher during office hours on Monday through Friday. And you can see our phone number there or use the QR code to get more information. You can talk with one of the psychiatrists and actually talk through the details of your own particular patients and their cases. We also offer resource navigation support as well, where you can ask questions about, I'm looking for a CBT therapist in this city who takes this insurance. And these can either be submitted by telephone or through our secure portal. And you should be able to get an answer by phone, generally within the half hour, or at a time that you specify, or by e-consult, generally within one business day. A couple announcements about our upcoming webinars. Next month, we're going to do a much deeper dive into the medications and CBT treatment, the elements, take-home pearls that you can use. So there's a deeper dive into the treatment, followed by a session on suicidal ideation. We also offer Project Echoes for primary care providers. Our advanced series is starting in February, so please be on the lookout for announcements coming your way. Topics will include trauma and disruptive behavior disorders. And then for our school-based personnel, we do have the school echoes occurring on Mondays. And you can see that we have topics coming up on substance use and school suicide prevention as well. I want to go ahead and put up this information for you because it can sometimes take a little while and be a little bit tricky trying to claim credit, but please refer to this for information on how you can check in and claim credit for today. And I believe there is a ticket system that, we'll drop into the chat in just a moment if you have questions or problems claiming credit for today. So with that, I'm going to go ahead and turn back to some of our questions. Our very first question for today is that many families are concerned about long-term use of SSRIs. Are they safe to take in the long term if the families are finding that the medications actually do help?
Go ahead and get started and you can jump in as well. Yeah, so I think it's a hard question in some ways because I think we understandably families have worries about long-term use of SSRIs. And there's also concerns for kind of long-term or undertreated anxiety and depression. So it ends up being a really individual, I think, risk-benefit analysis. I think in an ideal world, we would kind of have them be on the SSRI for kind of that 6 months to a year, and then be able to kind of hopefully taper off it without kind of relapse of their or reoccurrence of their anxiety or depression symptoms. And that's kind of what we hope for. And we also know that there's patients where when we do that, then the depression gets worse, or maybe they're okay for a while, but something else happens and they end up on the medication again, or end up on it for a longer period of time. I think there's, not clear studies or data that's showing particular concerns about long-term SSRI use. So it is something that sometimes people end up on long-term for treating their anxiety, depression. And, I think it ends up being kind of that individual weighing of the risks and benefits.
Dr. Reader, is there anything else you'd like to add?
I agree with Dr. Schumacher. I think, part of the reason that psychotherapy is recommended in every part of our algorithm is because, this is something where, with both psychotherapy and medications, I think we see similar changes to the brain and to neural networks in neuroimaging studies, indicating that like both can have very similar, impact for anxiety and depression. And one of them doesn't come with this concern about medication side effects. I think, the counseling around how therapy can be helpful can come into this conversation. We don't have tons of robust data over, the really long term in terms of some of the 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 side effects, over decades or that type of timeline. I think in the psychiatry community, it's generally considered safe because we do see many adult patients who've been on SSRIs for much of their life. And so it really is the risk benefit, as Dr. Schumacher is saying. I think, we may not fully appreciate sort of the morbidity and mortality associated with mental health disorders, the way that we think about with, physical health conditions. And so, with this idea that like maybe if we avoid medications, then we don't have these, negative effects. But in fact, depression untreated can have, negative physical effects for one's body, right? And so I think that's just the reality of a tough question. And I think if we're working with youth, it might be some counseling around, we don't have to make that decision right now. If we start an SSRI today, it doesn't mean we're committing to, long-term use. All we're seeing is like, how do they do? We really want them to, benefit in XYZ ways right now. And of course, we'll continue to talk about this and always try to see if we can reduce the dose or, taper once things are going better. So trying to alleviate that anxiety of, we're not making a decision today about your child's future.
Thank you so much. A question came in about what to do with diaphoresis, and I believe Dr. Schumacher entered an answer into the chat. But if you just like want to summarize that very quickly
Yeah, I
out
can
loud for the
speak to
audience.
it. Yeah, so for diaphoresis, yeah, that it can be tough sometimes. It's helpful to get a sense of how much is bothering them because for some people, they're sweating a little bit more than they used to, but it's something that they can manage. For some, it causes a lot of distress. I always check in first around environmental strategies. So often, in my experience, it often comes up like night sweats is where it comes up a lot. So like, are they wearing light clothing at night, using lighter blankets, trying to sleep in a cooler place, having a fan on, kind of seeing if they can manage it with environmental strategies. If not, trying a lower dose. And if no improvement with that, then can try switching to a different SSRI can sometimes, because even though all of them can cause it, sometimes for an individual person, it may affect do better with one or another.
Wonderful. A few questions came in regarding can we have lists of therapists? And for this, I actually encourage you, please go onto calmap.org, submit an e-consult to our care coordinators and let them know some details about your patient's needs, geography, like where you're located, insurance. You can get very specific recommendations there. For those who are old enough to do teletherapy, Rula, RULA, has been one place that I've sometimes been able to go to find online CBT therapy. Project Empower is a free 1 hour psychoeducational program that is based in CBT, and it is free. It's for the parents of school-age children with anxiety to help parents and help their kids with anxiety until you can actually get through wait lists and get to a CBT therapist. So those are two of my go-tos, like when I am really like stuck for wanting to get to a therapist. One of our participants has a question about EMDR as a therapy modality, and I don't know if either of you have some thoughts about that.
I think there's some emerging evidence. It started sort of with the adult population that EMDR can be an effective treatment for PTSD and anxiety related to PTSD. And I think that's starting to be replicated in youth. However, I don't know that there's enough studies around EMDR for other types of anxiety if there is no potential trauma. And I'm not sure about its efficacy in treating depression, especially if there's no PTSD or trauma related to sort of preceding the mood disorder. So I think it's sort of could be promising with an asterisk. We don't quite know enough now. I know that there's a lot of challenges and folks writing into the chat that it's hard to get like CBT trained, pure CBT therapy. And I think, that's something that I experience as well, just in terms of like, overall challenges in accessing care. And I think, wanted to make a plug for CalMap Care Coordination services here, whether they're struggling to find a therapist, or you're trying to find the kind of an effective type of therapy or evidence-based type of therapy for the family, our care coordinators are constantly updating their lists, and that could be a great resource for a patient.
I am a general pediatrician. I have used their care coordination and very specific asks, and they came back with great resources. So can't speak them up enough. I want to call out also Dr. Schumacher. You mentioned Clarity Pediatrics. Can you share further, please?
Yeah, so with Clarity Pediatrics, people they might be familiar with them from their parent management training offerings, but they now offer space groups, which is a specific kind of evidence-based anxiety protocol for parents of children with anxiety, as well as a teen anxiety group. So there's now, and it's all telehealth for kids and families in California, and they accept many insurance. So that can be an option to look at too.
Including many Medi-Cal managed care plans, which is huge. So Clarity Pediatrics, I've been using them a lot for ADHD, and it's wonderful to hear they've got some anxiety offerings as well. So with that, I want to thank our two speakers, Drs. Riederer and Schumacher, for this excellent talk today. Thank you to all our audience for coming and sharing your lunch hour with us. We know you're busy. We're so glad you're able to share your time with us today. We hope to see you next month for our next webinar, where we're doing a much deeper dive into treatment of depression and anxiety. Hope to see you then.